Welcome to the Healing Pain Podcast with Dr. Joe Tata. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tata.
Hey there, friends. Welcome to this week's episode of the Healing Pain Podcast. On this week's episode, we are breaking boundaries and discussing the crucial role of physical therapists in addiction recovery. My guest this week is Dr. Holly Johnson. Dr. Johnson has been a physical therapist for the past 32 years. Her clinical experience includes orthopedics, manual physical therapy, industrial rehabilitation, women's health, chronic pain, and of course, expertise in treating patients with addiction. Dr. Johnson is currently researching physical therapy treatment programs that focus on substance abuse and addiction recovery. This may be a new episode for physical therapists as well as other healthcare professionals and maybe even members of the public alike. The role of the physical therapist in addiction recovery is multifaceted, and it encompasses various aspects of the evaluation, the treatment of, and support in recovery and addiction. Now, upon first glance, it may not seem that physical therapy fits within the addiction realm, but in fact, physical therapy in mental health and addiction is actually a perfect fit. So I want to share a couple of things with you before we begin today's episode that'll help inform our discussion together and also give you a really good outlook and see the ways in which physical therapy, in fact, overlaps with mental well-being and addiction recovery. So the first one would be pain management, right? That's what this entire podcast is all about. We know that physical therapists are skilled in the evaluation, the assessment, and of course, addressing chronic pain issues. And chronic pain has many overlaps in people with addiction and substance use, which you'll hear later on today's episode. The next is someone's functional restoration or their functional capacity. Long-term addiction and long-term mental health challenges can take a toll on an individual's physical function and their ability to interact with their activities of daily living. We know that physical therapy treatment, of course, restores someone's physical capacity. It improves their strength, their flexibility, their mobility, their coordination, really anything that someone is struggling with. And ultimately, it enables individuals to regain a sense of independence in their daily activities. And that independence is really key because it can really help support someone's self-efficacy in the recovery process from addiction. The third is just exercise and physical activity. Research actually shows that when you embed exercise-based programs into addiction recovery, that individuals are more likely to adhere to an addiction treatment program. That's a big factor there with regard to adherence. The next is motivation and support. We know that as doctoral trained licensed health professionals, we understand how to enhance motivation and the importance of the therapeutic alliance. And when a physical therapist interacts with patients, they can help them set realistic goals, track progress, overcome any challenges that they may be facing, help them foster kind of this more positive mindset, which helps with creating a better narrative around the recovery process and enhancing overall motivation. And the last is psychologically informed care. So as physical therapists, we're now using tools and therapies such as cognitive behavioral therapy, acceptance and commitment therapy, mindfulness, pain education. All of those are really important with regard to helping people not only overcome pain, but also with the behavior change that's needed when someone enters into the recovery process for addiction or substance use. So keep those topics in mind and kind of use them as a guide as you listen to today's interview with Holly and I. And without further ado, let's begin and let's welcome Dr. Holly Johnson to the Healing Pain Podcast. Hi there, Holly. Thanks for joining me this week.
Hello, Joe. Thanks for having me. I'm just privileged to be here with you.
I'm excited to be speaking with you too. And I know this is I think it's somewhat of a novel topic for some of our colleagues, but I know there are definitely others who've been working in this space for some time. And a lot of people are starting to grow into the space and starting to fill a need here. So I'm really excited to talk to you about kind of your evolution and the things that you know, and some of the things you can share with us, some of your research later on in the episode that you'll share with us. But tell us how you became interested as a physical therapist in the field of addiction medicine.
Sure. I graduated from the University of Kentucky in 1986. So I've been practicing a long time, 36 years. But my first 32 years were in private practice in Appalachia. And that was ground zero for the opioid crisis, with really even before Oxycontin. And I didn't get any background training for that. Worked a lot with coal miners and did a general practice, women's health, family practice, and orthopedics, chronic pain. So just kind of was baptized in all that, and was really scary, because I had no idea that the physicians by the early 90s were saying, yeah, everybody should be out of pain. Everybody was an Oxycontin. And I saw families getting addicted, lost patients to ODs, bad drug deals, and even generational drug addiction. So we were trying with my company to combat that with several clinics, and just did not realize what hit us. And we didn't know what we know now, the whole Oxycontin epidemic and how it started with big pharma and affected little rural towns. And we were targeted. We are in the first Harlan in Appalachia. Those Eastern Kentucky, Tennessee, West Virginia towns were targeted as ground zero. And so I had to learn the hard way. So after doing that about 32 years, and then I divested of my practice and just wanted to see what else could be done, because the epidemic was growing again right before COVID and through COVID. I'm like, this is crazy. I am just, sick of this. And begin to learn more about central sensitization and just the trauma-informed care piece, and realizing that physical therapy, we need to know more about trauma-informed care, which is why I love your podcast. You've just done some great work with some really neat people that you can learn a lot from. So I just went into a addiction recovery center called ARC Addiction Recovery and said, could I try to see if I could treat some of your patients with musculoskeletal? I didn't even know if musculoskeletal pain was a problem, but I figured with a lot of my patients had gotten addicted, and a lot hadn't. A lot, because of physical therapy, they'd not used opioids or gotten off really quick after surgery, but this is just such a problem. I just thought, what can I do? I wanted to kind of go to the source. To me, that was the essence of early intervention for people with substance use disorder, if you can get there and when they're in detox.
Mm-hmm.
And so they let me do that 3 years ago. And I've been developing programs. I work mostly with women, but I do work with men too. But in the past, I've worked with both teenagers all the way up to 65-year-olds. That's the thing, is it doesn't, it's not a really respect. We're having 12-year-olds and older get addicted. And then, of course, a lot of OD deaths and a lot of people getting Narcan and brought back after ODs now. So we're seeing people after 5, 6, 7, what I mean by OD is, overdose deaths. So anyway, and just developing practice and realizing that PT, because I think it's more like 87% of people in substance use disorder report musculoskeletal pain. And it might be what started their pathway, or it might be just perpetuating the pathway.
Mm-hmm.
So, but PTs can be effective with, with getting people off opioids, meth, benzos, alcohol, the whole 9 yards, because that's really what I see a lot now is polysubstance people. But my work really began with opioid addiction. And so that's what my research is in that work.
So 87% of people with a substance use disorder potentially have a pain condition or musculoskeletal pain condition, shall we say. And physical therapy can play a role in, of course, we know pain recovery, absolutely, but also addiction medicine. I want to just kind of step back a couple of feet here, because we have a global audience who follows the podcast. And when you mention Appalachia, I know the region you're talking about and what that looked like as far as kind of ground zero in really the opioid epidemic. But can you paint maybe a little bit of a picture for those professionals and people who listen outside of the United States who might not be so familiar with where Appalachia is and really what happened in that area?
Sure. If you want to get a good documentary, the book Dope Sick is really a good way to, and there's a series on Hulu about that gives that what Michael Keaton, that goes over the details of how that happened. But it's really that middle part of the Appalachian Mountains, Tennessee, Virginia, West Virginia, very much coal mining area. Although that's not the only industry that was affected, many others were too. But primarily, a lot of people get injured there and had some generational chronic pain issues and disability issues too. And also typically can be a level of high poverty, and also not a lot of medium level physical demand jobs. There, a lot of heavy physical demand level jobs kind of help set us up for that. And sometimes low education rates, although you have professionals all through those areas, but you also have a population of rural, a little bit less educated, and a little bit more poverty, which is kind of sometimes a setup for, was a great place to start a marketing process if you wanted to pretty much put a drug in place that might be accepted more hook, line, and sinker, that was a great place to do it. And that's what, really Purdue Pharma did with OxyContin.
Yeah. So this is a region of the United States of America that tends to be lower socioeconomic, although not all of
Right.
it. It tends to be or have lower health literacy.
Right.
And the pharmaceutical giants, big pharma, basically targeted this area because they felt like they could be successful, which
That's
to a
right.
certain extent,
They were.
I don't
Yeah.
like to use the word success. They
Yeah.
increased the distribution of certain prescription medications so much that it impacted people's
Yeah.
physical health or mental health, and of course, their longevity, right?
That's right. And still is. That's the sad thing is that's what I teach in my elective. I teach at a couple PT schools third year to help students understand you're inheriting this and this is where it came from and you are a part of the solution. And I do feel better than ever that physical therapists, because we are the low cost musculoskeletal pain solution, and especially when you add pain neuroscience with that they really are a huge part of the answer, and not to get so discouraged that they just want to, because these patients can be hard, if you don't know that background, that a lot of what your podcast, provide.
So let's talk about DPT students for a moment. I teach as well at a couple different universities on certain topics, and I'm just curious as to what the feedback is from the students that you're interacting with when you come and you're having this discussion around addiction. Which it's interesting when you go to like the average, let's say, DPT program website, you
Mhm.
see things like sports and people doing exercise and yes, there's definitely the idea that we help people with physical disability, but addiction really does fall or straddles the realm of both mental health as well as physical health. So this must be something new for them.
Yes, it is. And what I've found is that's so refreshing is many of them are interested because they have a family member or maybe a personal experience or a friend experience of someone that's gotten in trouble, possibly with opioids, even if it started at a dentist appointment or with an ACL repair, or a family member, older family member. It's amazing how it now touches so many lives. And so they're more empathetic, I think, than ever any generation of PTs that I've seen, which is really neat. And they understand mental illness more because they went to PT school during COVID, and they saw how anxiety and depression went way up in what we call normal populations, and then people that were already struggling more. And so they're open to realizing that's kind of what your podcast shows, and some of my work shows, that we really do have an impact in treating anxiety and depression. And if you don't, especially if you can deal with the pain. And by the way, we do treat acute, subacute, and chronic, but the vast majority are chronic, and a lot of polytrauma with this group. So they have that combination of musculoskeletal pain, could be acute, subacute, and chronic, and then trauma and anxiety, depression, and some bipolar schizophrenia even, so it's been a unique awakening for me, even after, 35 years of practice.
So they're acutely aware of the problem. They've had family members and friends and potentially maybe colleagues or people they know that have
Mhm.
struggled with or are currently trying to cope with an addiction problem. And they're interested in being part of the conversation and being part of maybe a team of professionals who are helping people recover from addiction. So you mentioned psychologically informed care a few minutes ago. Tell us the tools, the strategies, the interventions that physical therapists have to evaluate, treat, and manage addiction.
That's a great question. I can tell you more about the ones I've been using. There's so many out there, it's almost daunting. I did develop one that we've researched. It's called the Recovery Exercise Program Index, and it's on my website. It's a free download for anybody that wants to use it. And it kind of takes the PNE, Pain Neuroscience Plus, kind of based on Adrienne Lowe's courses. That's kind of more my background. And it really measures pain neuroscience in it, addiction, your desire to use your drug or drink of choice, and also it has some questions about sleep. It has like the PQH and the GAD in there, kind of built-in, depression and anxiety screens. So it looks at some of those things all in one place for a PT, so you can see, well, how am I affecting these areas? I use that, but I put probably my tried and true one is I use the central sensitization inventory also to measure alongside of that central sensitization. And then I can use, you could use the Beck, or the expanded versions, of the anxiety and depression screenings. I definitely use an ACE score with every person I treat because I really need to know upfront how high are their adverse childhood events, how high up a score, because we know that if it's 3 or more, you're much more likely to develop chronic pain if you get injured and to maybe use opioids. So, and of course, body charts are super important. So I kind of over answered your question. You asked about mental illness, but I also work alongside counselors. So if those screens show we've got some anxiety, depression, they're going to be getting counseling every week. And that's what I love about doing physical therapy and addiction recovery is almost all quality, CARF accredited places have good counseling. And so, and I really encourage therapists, if they don't have that, to develop those networks and to help lead the team, because those mental health specialists are looking for PTs because so many of their patients have, musculoskeletal pain and they don't know where to find us. And sometimes we don't know where to find them. So to answer, you can do PTSD screens. I could do back, depression screens, but I don't spend a lot of time on those. I more do the shorter version screens and then send them on because I want to stay in my lane, and I want to stay in, I'm not a psychologist or psychiatrist. And I always teach my students, you don't want to let your patients make you that. If they only want to go to one place, you're not that person, for that. You are musculoskeletal pain, but you might be the first person that tells that your patient says, I was sexually traumatized, or I had a big trauma. I think I might have PTSD, or I may be struggling with anxiety. You might be the first person in taking your history. I'm finding that comes out, and then it's getting them to the right place and treating them together, because the brain has to have, my research, it has to have that both of those areas trained at the same time, because the brain gets all that mixed up and produces pain. Anxiety and depression can increase musculoskeletal pain, and musculoskeletal pain can definitely increase, anxiety and depression. So why would we not treat them together if we want to get good, low cost, great impact, outcomes?
Yeah. It's probably a good time to introduce our listeners to the types of places, or the place where you currently work,
Sure.
where you're treating patients, and just kind of give us the scope of what that looks like.
So I work at a place called it's ART, and it stands for Addiction Recovery Centers in Kentucky. And they have many centers. I work in a women's facility, a smaller women's facility. I work in inpatient, so people are coming there to detox their first 0 to 30 days, or 30 to 60, or even up to 90 days. And then I follow some people up long term. But that's one type of recovery where you actually go in, but then there's also outpatient where you can be, keep your job and that kind of thing. So, and we've done some toolkits with the University of Kentucky and Wisconsin University Concordia that kind of breaks that down, because we as PTs, I didn't know any of that stuff. I didn't know every state. There's some general things in each state, but there are different ways to get treatment. And so as PTs, we need to know, even if we're in private practice or a hospital setting, we need to know if there's a problem, how to help a patient get to the right place. And that's kind of hard for us because it's not anything we're taught in school.
Right. So there are obviously inpatient
And outpatient.
detoxification and
Right.
outpatient addiction
Right.
centers.
hmm
How did you approach these centers and start to develop a relationship with them?
Well, I thankfully had one in my hometown, and I had treated some of the people that work there. So they were open. And I'll just bring this in. At the time, we were seeing more MAT, that is the term that's called medically assisted treatment. And what that means is they were starting to have to offer a drug to help a person get off a drug. Typically, that would have been like methadone is the old one, which is an opioid itself, but it's a full-on agonist. So you are slightly high and impaired. And then the new one they're starting to do is Suboxone or buprenorphine, that's been around several, 10, 15 years. And then there's another one called Vivitrol, which is an injection that's not an opioid at all. And they were like, we don't really know. The patient gets to decide what they want, and you can't really give them informed consent. So the problem was all these people had musculoskeletal pain. And what we were suspecting is that they were starting to cause some of them were causing opioid-induced hyperalgesia.
Mhm.
And people were then, they were continuing on that substance, still having pain, never getting PT, and they might go out and then relapse and add more things. So we were seeing that as a problem. We thought Suboxone and buprenorphine would be the end all be all. I think that's kind of what the drug industry thought, and it's not in Eastern Kentucky where I work at all. It's causing some real problems. And we need research to know how important it is to get psychological care and PT when treating central sensitization. We didn't know that there's quite a bit of that in this population, and it's going untreated. So that's part of what is partly perpetuating our drug epidemic in the United States.
Yeah. Well, in many ways, physical therapy is in some way psychological care, actually, right?
It
We,
is. It
we know
is.
that
We are a
psychologically
team
informed
approach.
physical
Mhm,
therapy is part
mhm.
of a psychological approach. And,
That's right.
there's multiple organizations now. We have a catalyst group called Physical Therapy and Mental Health that I'm working on with a couple of colleagues and many people to help move that forward. So I appreciate you bringing all of this to light.
Yes.
So I want to talk to some of our colleagues who because I've heard people say things, I've heard our colleagues say things like this, and we can kind of role play through this, right? People need to be tapered or wean off their opioid or fill in the space drug first, then they can start physical therapy.
I love that you brought that up because what I've been learning is when physical therapists have that attitude, sometimes they're setting their patients up for failure because if there is, remember, addiction is the end stage of substance use disorder. It's a continuum. So and also I have that on the website, and that's just a DSM-5. You can send somebody to get evaluated for that. And we see people in our clinics all the time that have one, in normal, I'm not talking where I am now, but in normal private practice, in the hospital setting, even nursing home care, that people can be at that fork in the road and we can taper them off their opioids, but we've got to be there if there's musculoskeletal pain. We make such a difference. And also, if we may be the first people figuring out, hey, you've got anxiety and depression that's not treated. And if we treat that, your taper is going to be so much easier. So PTs, I feel like, can be the leader of the team of saying, wait a minute, yeah, there's musculoskeletal pain, and I can treat that with good pain neuroscience and good, manual therapy, exercise, and all that. But we need to be treating these mental health issues too at the same time. And then that makes the taper so much easier. So to say to somebody, you got to get off your opioids before I treat you, I think it's just setting them up for failure. I feel in my work, what I'm finding is they do so much better if they get the education first and you get to treat them a couple weeks and get the pain, let them see that those personal victories that they can get the pain under control. And then they're much less afraid.
Mhm.
They're much more open because it has to be their decision or it's not happening. That's the one thing I've learned, with motivational interviewing and stages of change. You're planting seeds and every year they're not ready till they're ready.
Okay, second scenario. As a physical therapist, I cannot treat a person who is currently taking a certain drug under the influence or may be impaired. It's contraindicated or will impact the outcomes of the treatment.
Well, it will impact the outcomes of the treatment, that's for sure. And we have to be so much more careful if they are impaired. And in being in Eastern Kentucky, I definitely had those times in my private practice where people came impaired, and I had to actually say, "You're not driving home, and if you do drive home, I'm calling the state police because you're not safe to be on the road." So I definitely am a proponent of tough love, first of all, and definitely had a lot of interventional meetings with families and family members of, so and so, Joe, you have a problem, and we care about you, and we've seen a personality change. And patients sometimes are ready to get something done, and some aren't. However, I've also had the patient that we just had to stick with and plant seeds. And they really would finally got to the point of saying, after maybe 4 visits, how do I really have a problem? I mean, and that's what we do with the toolkits of University of Kentucky and University of Concordia, Wisconsin. We have like 15 lessons for physical therapists that they can download and do with it, like 10-minute lessons that they can do because sometimes they can't hear it the first time. They can hear it the 10th time. They have homework, little homework pages and all that stuff, like 15 different ways to explain how we slide through substance use disorder and can get to the point of being in trouble. So, but there is also a time when you have to say, patient, this is all I can do until you're willing to address these, especially when it's high levels, benzos, alcohol, opioids, a whole lot high levels of drugs, and they really get to the point where they plateaued. It is definitely fine to say, we've done all we can do for now. I really encourage you to get some help. Can we talk to your provider? Because sometimes the provider's the problem.
Mhm.
They are the pill mill.
Yeah, that's right.
And that's tough. And we talk about, and have a toolkit for that too, because that's hard, is helping either educate the doctor, which you can do with these tools, or help the patient move if they're ready. And if they're not ready, a lot of times they're very codependent relationships between patients and providers
Yeah.
because they want customers, they want to keep their customers, and they don't necessarily care the damage that they're doing. And
Yeah.
the patient's okay with it.
Yeah,
I
that's
saw a
common.
stat the other day, still more people are getting opioids for back pain than any other care. PT comes in second, and patients like it. There's still a high satisfaction rate, it's because in the United States, we're a wealthy nation and our insurances pay for it. And we feel like we have the right to be out of pain, and we love to take a pill.
Okay. Final question before you move on to your research. So this question could be coming from a physical therapist. It could also be coming from a mental health provider who is listening to this episode. And the question often goes something like this. I can see how physical therapists can use psychological strategies to treat pain, but I don't see how physical therapists are trained to treat addiction.
So that's a great question. What I do in my work is I do a neuropain science lecture and a substance use disorder neuroscience lecture.
So you do, but so I want to just clarify. So it's a pain education lecture, right?
Yes.
Right.
But in it is, I have combined pain neuroscience and addiction recovery science. So it's very important to my patients. I've learned that they understand how their dopamine reward system got hijacked, because that's their why behind how I rebuild my brain. And it's also their why of how I retrain my brain to turn off the pain and reset my alarm system. So what I've found is those two things go together, that when a physical therapist understands how the brain gets hijacked, the dopamine reward system gets hijacked in any type of substance use disorder, and how that has to reset as you taper medication. And if you're doing physical therapy and increasing aerobic exercise and decreasing, just the reasons that their brain is producing pain, they get better so much faster. And if they have central sensitization, it gets better quicker. It's just like, why would we not hit all those things at one time? Why would not fire on all cylinders? So, and again, that's with counseling. I want to be very clear about that. That's not the PT doing that by themselves. They still need counseling for their trauma. There's a reason why they're using. And remember, it's very helpful when people have anxiety and depression. Even though opioids can incite depression, they can make it worse. Initially, it feels, and PTSD too, opioids feel like it's treating them because it's numbing the pain for a little while. It's quieting their pain and their anxiety, depression for a little while, until, of course, the reward pathway gets again hijacked, and those receptors want more and more, and you have to give more and more. And there's the whole dope sick thing that happens. So, patients that initially are just like, gosh, I'm desperate. Nobody's treating this mental illness issue. And so these medications are making me feel better.
Yeah. And it's an important point. I had this in one of my emails that I sent out a couple of days ago, that the pathways that create chronic pain and the pathways for addiction actually overlap and are very similar in some ways. And then
mom model, they do.
Right. And that sometimes pain can actually become the addiction.
Yes. And and then you add the cortisol dump in there. It's increased with depression, with anxiety, and with chronic pain, and with stress. That's why I think some people can kind of hang out on opioids for a little while at a certain level and be in that mid-range of substance use disorder. But then when you add the right life stressors, in other words, a reason for anxiety and depression to go up, or PTSD, then boom, all of a sudden it's not. And then pain goes up too. And they're like, in the brain, the frontal lobe says, hey, we need more medication.
Mhm.
But if physical therapy is there at that moment to say, no, let me problem solve why, what are the triggers here? And let's get counseling at the same time. That's the real treatment for the problem.
Mm-hmm.
Now, that doesn't mean that you don't need some SSRIs or SNRIs. They can be super helpful. But there's some drugs for some people that are just terrible. I mean, they just, they get a hold of the wrong drugs, or the providers, the prescriber's not paying attention. Because I really believe PT, behavioral health, and primary care just make such a great team. And that's really what every person deserves to have if there's mental illness and musculoskeletal pain and substance use disorder.
I know you've done some research in this area. Can you share some of the information that you have?
Sure, I can. And we're in the studies done. We've crunched all the numbers, but we're in the peer review process of finishing the write-up, submitting so we hope to be, to get published this summer. But the exciting thing is kind of what I just said is, first of all, we did not know in my setting, which is women in Appalachia, have about 90 some people in my study. they have high levels of central sensitization, and we did not know that was even a thing, and very high levels of anxiety and depression in the 90th percentile, so that's amazing. And then of course musculoskeletal pain. So I did not realize that was so prevalent, that combination of musculoskeletal pain, mental illness, and I'm not even counting the schizophrenias and the bipolars. I'm just talking about just garden variety clinical depression and anxiety. And of course, then substance use disorder. That's all admittedly, and it's polysubstance. It can be just alcohol, but also, opioids, the whole 9 yards. And what we found is if they get in early for their musculoskeletal pain and they get off all their drugs, and we help them taper their medically assisted treatment or get on the right one that is not an opioid or the lowest level, they do really well. But that's a combination of physical therapy and the standard care. Then addiction recovery is also counseling and group activities. So what we found is the number needed to treat is somewhere in the range of, if you treat 3 people as a physical therapist in that room, you're going to get like a home run. You're going to get people from high levels of central sensitization down to either no central sensitization or very low in maybe a month to 2 months time of treatment. And we're talking, I'm just giving you general ranges here, like 4 to 6 visits. I mean, it's so much faster than what I saw in my regular PT world, 32 years of practice. And that sort of blows my mind. That's exciting to me.
It is very exciting. And some of the research on central sensitization, we're aware of it in the world of pain, but there are some overlaps and some evidence of central sensitization occurring in anxiety, occurring in depression, occurring in
Right.
PTSD. So it's interesting how these,
Yes.
our system, so to speak, tries to peg these conditions into one category or the other. But I really think we're starting to see that these are diverse human conditions, overflow and overlap with other conditions. And with that, it actually makes our kind of our scopes and how we approach things somewhat permeable in some way.
Yes, that's right. And to the central sensitization syndrome people, the people that have IBS, TMJ, whiplash association disorder, chronic low back, that's what I see. There's so much of that addiction recovery because they've gone undiagnosed, and the psychological issues have gone undiagnosed too. And these people, gosh, when PTs get in there and make the difference, think of the cost savings that there is, and think of the quality of life changes we're making in people that who have destroyed their lives, or whose lives have been destroyed, seeking care, trying to drug and we call drug and drink their pain, their emotional and musculoskeletal pain.
Yeah.
So that's exciting, but also sad to me because there's such a shortage of physical therapists, and only 10% of people get to PT that need to get to PT. So that's why I'm really encouraging PTs to do this in their private practice, in their hospital settings, in their nursing homes. I mean, it can really be done anywhere, and to think about even going on site in an addiction recovery facility and or having them bring their patients to you. It can be done so many different ways. It's just really hoping that PTs, as they get educated, know that they really can make a difference. And if you have a good pain neuroscience background, you can't, and you're a good manual therapist and creative with exercise, you can't mess up unless you're going to be real judgmental. And as long as you have compassion, for people,
Yeah.
and realize that it is a brain disease.
So in addition to pain education, I'd add on to that some mindfulness skills really help.
They do.
Cognitive behavioral skills are really
Yes.
important. Motivational
Yes.
interviewing skills are really
Yes.
important when you're working with this group. So it's not just pain education that
That's
is
right.
going to move the needle. It's a combination of all the psychologically informed skills that
Right.
really become part of the treatment plan.
Yes. And it's what you need to use with every patient every day in every way. It's just that in this population, you're going to see even better results with people's lives who have been really screwed up. And that's kind of fun. And they are so appreciative because they've been waiting for this for 5, 10, 15, 20 years. And and they've they've hit their rock bottom. So they are very willing and ready in most cases to go. And I see people that if I had seen them in my clinic 20 years ago, it might have taken me 2 years to get them better, if at all. Or they would never have finally tapered off their Neurontin or their Lyrica or their Loratab. They would have lived on it. And because they've wrecked their lives and they've gotten to detox, they're like, I didn't know I could live without this stuff. And that's pretty fun for me, having seen what I saw for 32 years.
Yeah, and the physical therapy really builds their confidence and agency in having some
Self-efficacy. Yes.
control of their pain, some control over their body, some control
Yeah.
over their physical sensation and their thoughts and their emotions. All of that really folds into the mix there.
Right. And then they can get a job. That's what's so important. They can go back and either do their job without the pain that would cause them to use, or get a new job, or go back to school.
Yeah,
So
so
we're
I
it,
love
it's
that point because so often we're so focused on pain, right? We want to decrease pain, we want to eliminate pain, we want to control pain, which is how many of these people wound up in trouble in the first place, right?
right, right,
But really, I think what we should be doing as all licensed healthcare practitioners is yes, we obviously want pain to decrease. But more importantly, we want to engage people in a process where they can then be reintegrated into the community
right.
and have some type of meaning and purpose in their life.
Because we know that decreases relapse. They're
That's right.
much less likely to and become productive, citizens, and they're wonderful. By and large, they're just so glad to be helped that they can make great employees. And I call it lions and elephants. That once they address the elephant of addiction or substance use, and they don't feed that lion anymore. If you feed it, it can always grow again. But the same thing with like lion of central sensitization. We got to get that down to a cub level. And once they learn those coping skills, they are so grateful, and they work really hard at their recovery. They're so much more self-aware sometimes than our regular patients would be. And it's really fun too that when somebody comes into your office and says, I'm in recovery, and they're getting ready to have a surgery, prehab is so important for them because they can't take opioids on the way other end. And I have people now, Joe, I had a lady in my study that had a bilateral mastectomy and only used 800 milligram ibuprofen. And I
Well,
treated. Can you imagine? And they're doing those kinds of procedures, hip procedures, knee surgeries, no, orthopedic surgeries on 800 milligrams 3 times a day of ibuprofen. They're being put to sleep, the typical way, but it's the aftercare. And there's accountability because they're like, I worked too hard. I'm not relapsing over this.
yeah, that's an interesting point right there because I've had patients who have been in recovery for a number of years.
Mhm.
Then they wind up having a knee replacement or a hip replacement or a back surgery or whatever it is. It could even be an abdominal surgery, something that's not musculoskeletal related. And they're actually prescribed and told that opioids are safe for them. And it's, as us as professionals, we have to, walk that fine line with the patient. We have to walk the fine line with the provider and really try to advocate for them and mention that this might not be the best
Mhm.
prescription medication for this patient at this time,
Right.
considering that they have struggled with pain and addiction in the past. And that message, I think, has not been shared
Mhm.
throughout the pain, musculoskeletal, psychiatry, addiction world effectively.
I agree. However, we do have patients that can take 1 or 2
Yeah.
opioids, but they have to give them to somebody else. It has to be a person that understands. And it's the being honest with your doctor and saying, a lot of my patients will say, I have an allergic reaction to opioids. I said, yeah, it's okay to say that, but just go ahead and tell them you're in recovery, that you were addicted at one point. If they're open to do that, that just shows you how strong they are in their recovery. Some people really do get to that desperate point where they really want to relapse and they really want to create a musculoskeletal pain process because life has gotten tough and they're really having cravings. That happened a lot in COVID.
Yeah.
We saw that even Oxycontin use went back up. People went back to their old ways. And so some people had to rinse and repeat and start over. And I saw a lot of those patients. But some people really can take 1 or 2 and be fine. It depends on their brains. It really depends on, is their anxiety, addiction, and PT, all the other things, are they being treated under control? And are they in a supportive, work environment? And you're right, it's not a one size fits all. But I think it is important for patients. That's really that. And even in my index, I even measure efficacy, because if that's not going up, in how they manage their pain, we're not doing a good enough job. And it will be, you're right. Because if somebody wants to find something, they will find it, whether it's by prescription or off the street. They will.
Ali, it's been great speaking with you today about the intersection between physical therapy, chronic musculoskeletal pain, and addiction and mental health. Let the listeners know how they can learn more about you and follow your work.
Sure. I have a website. It's johnsonptconsulting.com. And everything on there is free to download. All the forms that I use, and I do teach courses if PTs want to learn how to do this in their setting, or and consult with PTs on setting up these programs, whether it's big hospital settings, nursing home settings, private practice, wherever, and then teach electives. So if I can be helpful at all, that's really what I want to do, is empower PTs to be comfortable and have their own self-efficacy in doing this type of work. Because it's not that hard. If you're a good PT, it really takes about a 8-hour training. And then I would also encourage these toolkits that the schools are doing, because it supports their chapters, which is great. And it's students that have really combed through the research after having my course, and then they produce some really nice tools. So University of Kentucky, APTA Kentucky's chapter has a good toolkit that you can purchase, or Concordia, Wisconsin University also are the two that are out there now. They're very good. And they all have like 15, 20 lessons on how to explain this. And then 15 frequently asked questions. And, how do I improve sleep after addiction recovery? How do I improve nutrition? How do I not relapse? All those things too. So, and then I cover that in my course. So I would love to reach anybody that wants to reach out. It's a great work, and it needs to be done all over the United States and the world. So it could be done internationally too.
I want to thank Holly for joining us this week on the Healing Pain podcast. If you are a professional who works in physical medicine and rehabilitation, or maybe you work in mental health or addiction medicine, or maybe you're someone who has a friend or a family member who is struggling with pain or addiction, make sure to share this episode with them on your favorite social media handle, so we can share the message that pain recovery and addiction recovery go hand in hand, and it is possible, and there's hope out there for the millions of people who struggle with both pain as well as addiction. I'm Dr. Joe Tata. It's been a pleasure spending this time with you this week, and I'll see you next week.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tata. To subscribe to the podcast and learn more, visit integrativepainscienceinstitute.com. That's integrativepainscienceinstitute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.